Hi, everyone. My name is Erin Bindock, and my resident research project this year looked into the impact of combination therapy and other risk factors on outcomes in patients with persistent methicillin-resistant Staphylococcus aureus, or MRSA, bloodstream infections. My research coordinator and I have nothing to disclose at this point. The objectives of this presentation are to identify risk factors for clinical failure in patients with persistent MRSA bloodstream infections. Additionally, we will evaluate the role of combination therapy specifically as one of these risk factors and its use in these MRSA bloodstream infections. A quick review of background information. We are all familiar with the major health concern that MRSA poses both locally and globally. It is associated with high mortality and risk of complications. There are many widely available agents. The recommendations from IDSA have not changed recently and still include typically vancomycin or daptomycin for long durations of treatment. These guidelines become less clear when a patient has a complicated infection, specifically persistently positive blood cultures. Depending on the literature you review, durations of 3, 5, or 7 days without clearing cultures can be deemed persistent. And this is a common indication for combination therapy. Combination therapy includes 2 or more anti-MRSA agents. Because there's limited guidance, combination therapy is often initiated at provider discretion. What we know at this point is that combination therapy has shown a decrease in time to culture clearance, but increase in potential for adverse effects. What we still don't know is which patients will benefit, what agents should be used, when they should be initiated, discontinuation or de-escalation of therapy, and if there is even a benefit in patient outcomes. The main takeaway from each of these articles, McCreary and colleagues found that there's no mortality benefit when comparing standard of care to daptomycin ceftaroline combination therapy. Minahima and colleagues found in a retrospective observational study just how detrimental persistently positive MRSA blood cultures can be, and mortality increases 16% each day that cultures stay positive. Alisamy and colleagues found that combination therapy was associated with decreased risk of clinical failure. It's important to note that their definition was a composite endpoint, and what really drove the endpoint was clearing cultures quicker. Their study did not find any mortality benefit. Our study took place at the University of Tennessee Medical Center in Knoxville, Tennessee, which is a 680-bed academic medical center where clinical pharmacy is closely involved in academic use and stewardship. And this was a single-use IRB-approved retrospective cohort that took place between 2016 and 2020. Our population included persistent MRSA bacteremias in adults that we defined as 3 or more days. Patients must have received anti-MRSA therapy within 48 hours of positive blood cultures. Patients were excluded if there were no repeat blood cultures or if they were polymicrobial. The design of our study looked at patients with poor outcomes and patients who did not have poor outcomes, and we evaluated their risk in each arm of the study. We defined poor outcomes based on the patient meeting the primary outcome, which was a composite endpoint of clinical failure at 90 days. And this was composed of infection-related readmission, relapse of infection, so new positive cultures after previously negative culture, and all-cause mortality. For our statistical analysis, the study was powered at 80%. We included 192 patients. Of those, 43% met the primary endpoint of poor outcomes, and 57% did not have poor outcomes. I conducted a student's t-test for discrete variables and a chi-squared for continuous variables. Additionally, I did perform a multivariate regression analysis on variables with a p-value of less than 0.2 or that were previously agreed upon, like combination therapy use. Baseline characteristics across the 2 arms did not significantly differ. The average age was about 46, and about 60% were males in each group. Mild liver disease was the most common comorbidity and was fairly consistent across the 2 arms. Diabetes with end organ damage and moderate to severe renal damage both correlated strongly with poor outcomes. For infection-specific characteristics, it's important to note that endocarditis was the most common infection source, and this was not statistically significant, but strongly correlated with poor outcomes. Additionally, obtaining source control via penumbra was statistically significant for its correlation with worse outcomes. Combination therapy was one of the specific modifiable risk factors that we investigated in our study, and you can see that there was no significant difference in patient outcomes across the two arms in patients that received combination therapy or did not. I included daptomycin plus ceftaroline as this is the most common combination therapy at our institution, and it was also not associated with a difference in outcomes. Of note, time to clearance was also improved in patients that received combination therapy with a median of 11 days versus 7 days, with a statistically significant p-value of less than 0.001. The multivariate regression analysis demonstrated that when we controlled for potential confounders, the variables that most closely related to poor outcomes are diabetes with end organ damage, endocarditis as source of infection, and prior hospitalization within 6 months. Some limitations of the study included that it was a retrospective cohort. There was a proportion of patients that left against medical advice and thus were lost to follow-up, and that combination therapy is prescribed at providers' discretion here at our institution. In conclusion, we found that the predictors most closely associated with poor outcomes in MRSA bloodstream infections included chronic comorbid diseases, critical illness upon presentation, and recent hospitalization. Combination therapy was not associated with improved outcomes, and its initiation was often delayed in days into the treatment course. For our free response self-assessment question, what effect on patient outcomes was observed in patients that received combination therapy? And the answer is that there was no improved outcomes observed. Thank you so much for your time, and I'd be happy to answer any questions that you may have.